No conflict of interest to disclosure. And well, I hope that at the end of the presentation, you guys will understand a bit more about the UTC, how we acquire, how the data process, and then how we analyze that to differentiate the UTC from ultrasound, that we can recognize some clinical implications of the UTC when we assess tendon pathologies, and to identify tendon tissue in the UTC generated images, and how to interpret the reports. So what is UTC? What is that? So it's a new ultrasound probe of 5 to 12 megahertz that it's coupled with this standoff pad. But the innovation about that is that they place this motorized tracking device where it fixes the probe into transverse position to prevent tilting while acquiring. So during the swipe, the probe will glide down through the tendon length, and it will acquire about 600 images. Every 0.2 millimeters, it gets one transverse image of the tendon like this one. Oh, there's no pointer. So the system will pile up all these 600 images like this, and then because of that, you are able to see the tendon three-dimensionally. It's almost like a tomography. So you can glide medial to lateral, you can glide anterior posterior, and you can glide throughout the 600 images that are the real images acquired. So it builds up like a 3D block that you can explore around. But how the algorithm works, what does it do? It gets each picture and compares with two previous and two after to see how it is the structure present in this image. So it combines all the correlation with these successive pictures, each block of 5, and go 1, 5, 1, 5. And then observe if how is the echo pattern, how stable is that, how homogeneous is that, the alignment of the pixels between the images. And from that, they will color code the pixels of each image, which gives 4 grades. The green one is echotype 1, that the fibers are completely intact and taut. Then you have the type 2 blue, that are a bit wavy and not like swollen, but is still healthy tissue. Then you have type 3 and 4 that are irregular tissues or even liquid in the black, the type 4 case. So what is the output? If you see on the top image there, like it's the patellar tendon, the unharvested one, with a drawing around. The examiner is responsible to determine the tissue of the tendon. Then from there, the software will give you the proportion. I should have can I have an arrow here or no? Well, it should have the proportion of echotypes 1, 2, 3, and 4 in that slice that I draw. If you see the top of this image here, there is a yellow bar. That's the area of the tendon where we are analyzing and giving the proportion. Similar on the other pictures, you see on the top the yellow bar at the very top of it. So here comes the report. In the report, you will see every single bar yellow place that you can determine to see which area you are interested at and see the proportion of echotype. So then on the left, you will have the sagittal view of the tendon, and then the 4 images that the examiner selected to put on the report. And then on the graph at the end, we'll give you the proportion of the 4 echotypes. In this case, it's a very healthy tendon with a high proportion of echotype 1, that it is the more aligned fibers, the echotype 2, intermediate, and then the 3 and 4, that it's in very small amount. Also, the more contours, the more information you provide for the system, at the very bottom you have the volume selection, that it was by the choice of the examiner. In that case, it included the whole tendon. So many studies, radiological studies in equines were done before it culminated in the more important one in my perception, that it is the matching histological specimens between radiology images and the specimens of these the horse tendon. So they generated several, like the injury, induced an injury, and then they observed the matching situation with the ultrasound. From there, they generated the algorithm that acknowledges how the structure of the tendon is, from a normal young fiber to an old fiber, and then throughout all the phases of regeneration. But then what's the difference between the ultrasound and the UTC? So it started in horses, so I wanted to honor that. So the principle of them are different. The ultrasound, the regular one, is a 2D grayscale images from reflected echoes. But on the other hand, the UTC analyzes the echo part and how stable are these pixels across multiple sequential images. Then the output for the ultrasound, we know it's very, very nice and accessible. It's real-time cross-sectional imaging, while on the other one, it is a color code based on the integrity of the tissue. The operator dependence, it's very subjective in the ultrasound, the regular ultrasound, because the interpretation between examiners varies a lot, while on the UTC, once you're trained, it's highly objective and it's algorithm-based and it's highly reproducible, as you were going to see. Then, in terms of dynamic imaging, of course, the ultrasound, the traditional 2B mode is dynamic. You can contract, you can be active during during the acquisition. While for the UTC, I barely ask them, don't laugh, don't talk. It needs to be very steady. For the clinical use, it's widely usable, the B mode, because you have it everywhere, but the UTC is a bit more costly and it's limited availability. In terms of sensitivity, for the ultrasound, it detects tears and calcifications, is more gross detection, while for the UTC, you have more detailed information and you can see subtle changes in the collagen alignment. For the ultrasound, as I mentioned, is limited reproducibility, and for the UTC, it's excellent for longitudinal monitoring, and UTC is best for research, for rehabilitation follow-up, and to observe subtle changes in tendon. While for the ultrasound, it's really quick to get an answer, like in dynamic studies. Okay, so the UTC has been shown some diagnostic values, okay? So when they assessed Achilles tendons, this is one of the pioneers, and actually the first study in humans was in Achilles tendon, and they observed a very high reliability for the data collection and analysis. They noted that the symptomatic tendons, they presented high proportion, reduced proportion of echotype 1 and 2, of course with the associated increase in echotype 3 and 4. And they observed that when they set a threshold of 75% of echotypes 1 and 2, below that, they consider the tendon as pathologic, okay? And they managed to detect with 83% accuracy the tendons that were really symptomatic and pathologic based on the UTC images. Then they also observed that when compared MRI, ultrasound, Doppler, that the UTC, the presence of echotypes 3 and 4, revealed high accuracy in determining the mid-tendon Achilles pathology. So it is a good system for acknowledging and diagnosis. Then quite a few interesting studies came up to observe the answer to load after exercising. So one of these studies with Australian football players, they observed the Achilles echotype distribution at baseline, and then 1 day after the match, and then 2 days after the match, to observe that there was a decrease in echotypes 1 and an increase in echotype 2. This one has been called as a reactive response to exercise. I call attention to the minimal detectable change because the difference to me looked quite small, but for this study, they observed significance already with this. Their minimal detectable change was quite low. But other studies, when comparing patellar tendon of teenagers, they observed no difference in echotype distribution during a 5 days tournament, volleyball tournament. And they calculated the amount of jumps, the hours, the matches, everything, and there was no change. A more recent study observed the Achilles tendon of the marathon runners. And they observed that 2 days after the marathon, nothing has changed with the tendon. It was exactly the same. They were professional runners, okay? But then they said that from day 2 to 7, they could do whatever they want in terms of sports. So most of them ran again. And then on day 7, they observed a significant decrease in echotype 1 with a similar significant increase in echotype 2. Again, a reactive response, as you can see here in the picture. So what they propose is that you really need to check it out the load after an intense exercise like that, because perhaps you're trained for that, but then the cumulative load during that week can start generating responses that perhaps the tendon is not capable to tolerate. So how was the story of UTC in Aspetar? Everything started when our medical records actually were coming to us by trolleys with the porters, and we would receive like 100 of those before starting the shift. At the time, the ACL group was seen in groups, like as I said, and so they would all come whenever. So we had sometimes 18 guys at once, and the physios were actually seeing the patients 3 times per week. On the other 2 days, they were doing hydrotherapy and fitness and being assessed at intervals of 6 weeks. At the time, the same physios that were treating the patients were doing the data acquisition on the other 2 days. And the tests, as you can see, are pretty much similar to what we do now. Of course, we have way more detailed information nowadays and actually organized. So at that time, they acquired the UTC and they said, now you do it. So we started acquiring UTC without much structure yet. But when we see the ACL patients, and fairness, every knee patient, we will observe all these symptoms around. We see that they may present with persistent pain, swelling, deficit of strength, limited function, the limited range of motion. And one of the issues that we face is the restricted extension and anterior knee pain. That was always banging in my head. What can we do to make this better? Can we see what's happening there? Can I exclude at least one source of pain? We all know that there is a bunch of things that can cause the anterior knee pain in our patients. Pre-op, and then after the surgery, we still have the portals and the fat pad. That can be a nightmare. And then I said, okay, we have a lot of sources in there, but what about the patellar tendon? The literature is very consistent in blaming the harvesting of the patellar tendon as a source of anterior knee pain. And it causes, of course, the quadriceps inhibition, persistence weakness, the things that we see, and the tendinitis and tendinopathy. So in my mind, I said, can I exclude that from the problem? At least one thing down. So that's when we started putting things together and saying, okay, can this become a project? And then here we started. So we were already assessing the patients 6 weeks apart. During the clinical assessment, we were seeing, I was taking into consideration for the study the pain scores, range of motion, swelling, laxity, the biodex strength. When I started, we were including everything, the quads, hamstrings, the peak torque by body mass, the ratio, seeing the curve patterns, and all the echotypes, 1, 2, 3, 4, multiple areas of interest, everything that you can possibly imagine. So then here comes the study goals. I wanted to investigate the patellar tendon quality during the rehab after injury and the reconstruction. First, I needed to validate the UTC as a reliable tool, and I needed to I wanted to establish reference values for these patients during the injury only, not the reconstruction, to compare outcomes between the graphics, BTB and hamstring, and to identify clinical and functional factors that were influencing tendon healing and strength. So the first study was the reliability. We had 37 patients included, but in different situations. We observed the proportion of echotypes 1, 2, 3, 4, the sum of them, as most of the studies use, cross-sectional area, tendon length and thickness. And then the tests were done, me, Rafael and I, to test harvested, unharvested, to test a mix of everything, to see during acquisition and analysis. And we measure, of course, the standard error of the measurement and the minimal detectable changes. I'm not bored too much with tables because it's quite big. There was 6, 7 of them, but I brought just a few of them just to highlight that it is highly reliable. I was measuring at apex, 5 centimeters down to apex, 1.5, 75% of the tendon length, and then the overall tendon. And considering the whole tendon, the proportion of echotypes. So you do have a very high reliability while assessing either intra or inter reliability. And of course, highlighting the minimal detectable changes. That for us is what is relevant when we are reading any paper to see if the differences are actually significant. Similar pattern was observed during measuring the length, the thickness, and the cross-sectional areas at 0.5 centimeter and 1.5. In that case, the inter-reliability was a bit better than the inter. So from the reliability study, we saw that harvest tendons showed excellent reliability, which was novel. No other study had seen that for the harvest tendons. More contours gives better reliability. For less contouring, you would choose for testing the mid-tendon area because it also brings better reliability. The sum of echotypes 1 plus 2 is better than just checking them separately. That's the reason it's common in the literature. And in unharvested tendons, a single examiner showed to have much better reliability than inter. Always consider the minimal detectable change for meaningful changes. So then it came with the study 2 that it was the pre-op assessment. I wanted to check the patellar tendon quality, the quadriceps strength, and to see correlation of them with all the variables that we see during the clinical variables that we see. For that, we included 81 patients assessed preoperatively. And we observed that the injured knee presented deficit of extension. They presented reduced knee angles. And then 38 of them presented knee pain. They reported an average of stability of 6 out of 10. And they presented reduced quadriceps strength in the injured leg. In my mind, that was like, okay, if they are weaker, they are not loading so much the leg, the tendon will be different. That's, we know that deloading a limb would cause adaptation in tendons. And then our preoperative findings was that, but we need to bring it up, that while we're doing the pre-op assessment is when we observe pathologies, right? So in this case, we can see a jumper's knee or the patellar tendinopathy proximal to the patella. Can you see where it is the injury? Because I don't have the pointer. So here you see thicker and darker, thicker and darker. And that's seen prior to surgery. Also, during the preoperative assessment, you will see the presence of osgood chilater, and also if you have the Sinding Lars, which is similar to osgood chilater, but in the patella. This is part of the preoperative assessment findings. And we all know from the literature that if you do have already any echogenicity, low signal, or hypoechoic or thickness, you have elevated risk of flaring up this tendon after training. So it's 4 times higher risk if you present that and is asymptomatic when you go for training to develop pain. But despite the weak quads and everything, there was no difference in echotype distribution between injured and uninjured leg. For everything was similar in all parts of the tendon, and including the overall tendon. So here you have all of them presented in similar patterns, despite some of them having an injury here and there. The values that we observed are in agreement with the literature. So although some window size difference, which gives more or less detail for the images, the distribution of our patients, although injured in ACL, were similar to the ones seen in the literature. Regarding the relationships between the tendon quality, the quadriceps strength, pain, we observed very weak to moderate statistical relevance in it, but we can see that we experience is in the clinical setting, that we observe that longer time from the injury, the tendon looked a bit better. So you had a tendons of more ecotype 1 and 2 and less ecotype 3 and 4. With the reduced quadriceps, it was associated to knee pain, depth of extension, and reduced stability. While if you had stronger quads, you were loading more, you had no pain, and you had no extension deficit and better stability. This is pre-op. Very good. Then we go, okay, now we need to see that in the long term, right? So we assess the patients from pre-op to 12 months post-op. But in this case, I included everyone. I wanted to see the reference values for each time point and to assess for anterior knee pain prevalence. So we had 10 people who are conservative treatment, so they were only included in the pre-op phase. And then we had 110 participants with BTB graft and 64 with hamstring graft. The goal was to establish reference value for every time point for the patellar tendon and strength, and to compare outcomes between grafts, BTB and hamstring. So there was absolutely no difference throughout the whole 12 months for hamstring grafts. Some points in there you will see some significant statistical significance, but the difference was not superior than the minimal detectable change. While for the ACL patients, we saw that they had reduced ecotype 1 and increased ecotype 3 and 4. And one interesting thing for me is that ecotype 2 actually stayed the same. It stayed the same, or it was in always continuous transition that you were getting ecotype 3 and 4 coming into 2, while 2 was going into 1, because we do see an increase in ecotype 2. But like to put ecotype 1 and 2 together kind of doesn't make sense, because then, you know, I would prefer to see them separately to see more nuances. So here you see just a picture showing how it goes throughout time. You do have an increment in ecotype 2 for the increment in ecotype 1 over time for the BTB operated leg, while you have a reduction of ecotype 3, mostly the 3. The 4, the black one doesn't, it kind of stays steady. And well, what happened in there? And that was in 2 different areas of the tendon. Cool. While for the cross-sectional area, the tendon remained thicker than the uninvolved, unoperated tendon in both areas, as would be expected and as in agreement with the literature. So about the anterior knee pain prevalence, we observed that 112 patients reported anterior knee pain at some point during the whole study. And from that, we observed that there was most of the time no difference between BTBs and hamstrings. The only time that there was more BTBs complaining of pain was in 7.5 and 9 months post-op, and which there were many more BTBs at that time. And we noticed that the 4 last assessments, these patients all have had complaints of anterior knee pain from day 1, which tells us like literally the anterior knee pain is a big problem for us that we need to solve the earlier we can. So the final study is the longitudinal one, that it follows the patients from beginning to end, and included only 62 patients. As we know, it's very hard to have a complete data set for a patient. And in this case, we included people with more than 4 assessments, which is a total of 9 possible during the first year. So we also wanted to compare the patellar tendon quality and quads strength, and we wanted to see if we could predict what could make the gap better, during the rehabilitation. the harvest gap, the donor site, to be healing better. So in here, you can see that the first two pictures are a regular unharvested tendon. The second pictures in the middle there, it is the whole harvest tendon, including the remaining tissue and the harvest area. And the third contour, it gives only the gap, the donor site, okay? And in this study, I didn't consider the whole tendon. I consider only between 0.5 and 2 centimeters of the tendon. So the information is at the center of the tendon. So we observe similar pattern than the longitudinal one, that we saw that reduced amount, the column there is related to the gap in comparison to the uninjured tendon, okay? And there was a reduced proportion of echotype 1 with increase in echotype 3 and 4, significant one. And also, we observed that the cross-sectional area was tending to go symmetric or closer to the uninjured, which in the case of cross-sectional, at the 2 months, 12 months target, it was already matching the pre-injured levels, but the thickness remained thicker throughout the whole time. So imaging studies about the healing of the harvest tendon is quite contradictory. Some studies with MRI and ultrasound mention gradual reduction in tendon width over time, while others will mention persistent enlargement or even no significant change in only one study and quite old. And there is a persistence of the donor site gap up to 12 months. But MRI assessments mention that the healing process is very different from individuals, and that the remodeling starts to slow down after 6 months, but it continues until the 12 months. In this image here, we can see the trajectory of all the 62 patients. And if you look closely, you see that there are some people who finished with nearly nothing of echotype 3 and 4, and like had very good tendon distribution for echotype 1 and 2, and others were very going like high in the negative echotypes. This is an example of beginning to kind of end, and you can see the changes in the grayscale, that it gets more homogeneous, and here in the color code how it starts very red in the tendon area, and then it tends to go down and down. In the sagittal picture, it depends on where you do the cut, bless you, where you do the cut, because then you will see more or less of the irregular tissue. So our findings indicate that the harvest tendon remodeling progresses slowly, and that it's at the 12 months it is still incomplete. So for the quad's strength, we can also see that the patients have different behavior throughout the rehabilitation. We also see that until 12 months there was difference in strength up to the end. And it's interesting, I should have included the range, because you have someone giving 400 peak torque, and another one giving very little. And at this stage, I hope you guys are doing better now, because at 12 months, they are still having only 2 times the body weight. Not cool. And in terms of relationship, there were different relationships of different strengths. For the tendon, to observe better harvest patellar tendon quality, which meaning increased echotypes 1 and 2, it was associated with higher hamstring strength, which in my mind it can be only that, okay, he has a nice knee flexion going on, and then he is able to stretch more this tendon, breaking my head to understand. Increased load exposure, and then reduced extension deficit. Oh, not yet. Back. For stronger quads, you will see also many relevance in there, but like in the short discharge time, they needed to have less extension deficit, less swelling, and less knee pain, which is kind of intuitive, but like in your face, it's really happening. You need to put all together. And for me as a physio, when I see, okay, it's a weak relevance, but seeing in the clinical that it really is relevant for us, kind of makes sense to me, but not for science. Anyways, then in the study of early predictors, we observe that better tendon quality, better gap quality was related to reduced extension depth, increased difference or more swelling actually, and reduced load exposure and absence of anterior knee pain. At the same time, you had increased poor gap quality. You had presence of anterior knee pain, presence of extension deficit, increased flexion angle, decreased swelling, and increased peak torque. So strengthening there was giving as an opposite goal as I thought or wished. In terms of time for discharge and also achieving 10% of symmetry, we observe that increased likelihood to achieve quad symmetry in when you don't have anterior knee pain, or if you have less swelling and more echotype 4. But the discharge time was reduced in the presence of swelling, reduced swelling, and you had a strong hamstring, and also a strong quadriceps peak torque at 3 months. So the main findings from the studies, and starting from the reliability study, is that UTC shows top reliability for harvest tendons, and the more contouring you do, the better. Evaluating the pre-op tendon quality and the quads strength in ACL injured versus uninjured legs, we observe that tendon quality matched both legs despite the weaker quads in the injured leg. When we saw the patellar tendon following the reconstruction, we saw that lower tendon quality in harvest tendons was in comparison to the uninjured leg and hamstring legs, and that anterior knee pain is equally prevalent in BTB and hamstrings throughout most of the time. Regarding change over time, we saw that harvest tendon and donor site gap quality does improve over time without reaching the unharvest tendon or pre-op values. About the early factors interfering with the gap, poorer tendon structure and larger tendon size were linked to more knee pain. There was no clear link between tendon quality and quads strength, which was surprising for me. Worse tendon gap quality was paradoxically associated with stronger quads. Better gap quality linked to less anterior knee pain, but also weak quads and less loading. For achieving quads criteria of under 10%, it was linked to less swelling, more anterior knee pain, and worse gap quality. And the discharge time was faster when the quads and hamstrings got stronger faster, less swelling, and there was a good pre-op tendon quality. The take-home message is mind the gap. If you don't scan, listen closely. Without tendon monitoring, anterior knee pain might be your only sign that quads strengthening is upsetting the donor site. So scan regularly, load smart, and find balance. I would like to thank you guys and the patients who took part of this very long study, and everyone who's directly or indirectly helped me during this process. Thank you very much.